Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is July 12th, 2022, and I want to thank you for joining us. We are continuing every Tuesday at 11 to bring you a Facebook Live, and generally each week we're going to have a combination of COVID updates and then a focus on another issue. So, for example, last Tuesday we devoted much of our conversation to monkeypox, and I do have a little bit of an update on that today. Today, though, we've made a number of changes to our dashboard, a number of updates, so I am going to keep the focus today primarily on COVID. As always, you'll be able to put your questions directly into the box below using the hashtag AskDrArwady on either Facebook or Twitter. We will first go through the dashboard and some of the changes that are in place. Then I've got some slides on questions that have been coming in and some general updates, and then we'll turn to your questions. So as always, chi.gov/COVID- is how you get to the Cities of Chicago's COVID-19 dashboard. We continue to update this every day, Monday through Friday. So as we pull it up here, you can see that we are back at a medium level. I will just go ahead and highlight right now that this level reflects not just how Chicago is doing, but Cook and really the suburban area from a hospital perspective. And we are right on the borderline between medium and high. So last week we were high, this week we dropped down to medium. We are seeing a lot of cases, especially with BA.4/5, and we'll talk about that. But we may bump back up to that high level. Either way, we're not seeing a major surge. We continue to be really kind of right on the border, and I'll show you those numbers in a minute. We update that weekly. The CDC updates it generally Thursday nights, so Fridays is when you would see the updated level, the COVID community level for Chicago and Cook. So we have made a couple of changes to the primary page here. So if we take a look, cases, hospitalizations, deaths, and vaccinations have not changed, but we've replaced what used to be testing numbers with emergency room visits, and we've replaced what used to be positivity with hospital beds in use. So I want to talk about that. We put up at the top here an explanation of this. So the summary was updated to include those. You can still find that original testing information. So I'll show you where that is, but remember that this is where you can get right here along this border here, this testing here. If we click on that, you'll see it brings us, and there's the positivity rate. It's 11.7%. There's our daily average test. You can see what's happening with positivity. You can see what's happening with tests. But the reason why we have taken it off the homepage is that testing just doesn't mean the same thing that it used to mean, given that most people at this point are using home COVID tests. And so what we are using more, and what the CDC is using, are these metrics that are not dependent on how much home testing is occurring. So the emergency room visit, if you click, you can see this is the percentage of all emergency room visits by Chicago residents associated with a COVID-19 diagnosis. It's a 7-day rolling average, and you can see back over time, this has been actually a very predictive indicator for us. It's been one of the earliest and best ways for us to see how we're doing in terms of both severe illness, in terms of how hard the hospital might get hit. You can see that in January here was the highest, where nearly 20%, 1 in 5 people coming to the emergency department for any reason, all had a positive COVID-19 test. So as you can see, that's just been sort of slowly trending up here over the last few weeks. Hospital beds in use also, this is all the historic data going all the way back to the beginning of COVID. And again, reflects what we've seen pretty clearly with the different waves. And you can see this has really remained flat here in Chicago. And if you can click here and see more details, the percentage of all staffed inpatient beds, meaning hospital beds where people stay overnight, what percentage of our staffed inpatient beds in the city of Chicago, meaning all hospitals in Chicago, are occupied by patients with a positive COVID test, whether they're in the ICU or the non-ICU. This is the same data that has been available through our hospital capacity dashboards and others, but we've moved them up to the top metric. And you'll see in the daily posts that we are putting on Facebook, et cetera, wanted to adapt it to really show a lot of what we're following as we're making decisions. You've heard me say a lot that if we were to need to put additional citywide restrictions, new requirements in place, it would be if we were seeing our healthcare system getting threatened like we were in January. So you can see from these graphs, we are a very long way from doing that. I also just wanted to remind you that at the bottom here, we've got direct links to a lot of the things that you all write in with the most questions about. So if you want to see the most up-to-date data about variants or wastewater surveillance or hospital capacity or what's happening with community levels across the country, if you want to see the vaccine effectiveness data here in Chicago, you want to see some social impact, you want to download the data yourself with the data portal, you want to go to the Health Atlas and see how COVID data fits in with all of the other health metrics that the city traces. And then vaccine coverage, we have also made some updates to. So I'm going to click here. Just as a reminder, you can either click on the bottom, or this is the same data if you come up and click on the vaccine tabs here. So you can get to places multiple ways. But if we look at the vaccine coverage data, there's a few updates. So first of all, as promised, we have updated. There's table data and there's metrics data. So this is the table data, but if we go to the graphics, which are a little easier to see, we've added the 0 to 4-year-olds. And you will see here that all Chicagoans, just over 77%, have had at least one dose of a vaccine. In that 0 to 4 age group in the first few weeks, we are at less than 5%, just 4.5% of 0 to 4-year-olds have had that first dose. Now, we know that the kids who are between the ages of 0 and 6 months would not get a vaccine. The protection they get is from the vaccines that their mom has had. But nevertheless, this is low. I told you last week it's been low. It is higher than what we're preliminarily hearing nationally. Nationally, we're hearing only 1 to 2% of people 0 to 4 have had that first dose. But nevertheless, I remain concerned about this. And we obviously are continuing to work on it. So this is where this is. But you can, if you want to look by age at what's happening with first dose, completed primary series, or booster dose, if you want to look by race or sex. And then we've also added a combination of age and race ethnicity, which is something that we had been producing but have now standardized as something that will update regularly on the dashboard weekly. And so I thought I would just talk you through this a little bit to give you a sense. So again, you can get this up here on the right if you want to get it as a table, or you can get it as a graphic. So this defaults to Chicagoans age 65 years. And so let's just kind of talk through what this looks like. If you look at people age 65 years, I remain the most concerned about this group, given that this is the group by far the most likely to get hospitalized, have serious outcomes, or die if we're not vaccinated. And you can see that 81% of white Chicagoans over 65 have had that first dose. Only 71% of Latinx Chicagoans in that age group, and then 76% of both Black and Latinx. And then it goes from there with completed primary and boosters. But you can click here on the right if you want to see what it looks like in other groups. And I just wanted to point out, there's a nice way to sort of visually get a sense of this. People often write in wondering about the details of how age and race overlap and ethnicity. And so you'll see here, for example, that Latino Chicagoans, except for in this oldest group, 65 plus, where we are still seeing lagging, and then in the young children, the 5 to 11-year-olds, we're seeing lagging in Latino Chicagoans. In all of the other age groups, Latino Chicagoans are actually more likely, if you look at the blue compared to the red, to be vaccinated than white Chicagoans. And so it really, for example, our partners use this data if they're working especially in predominantly Latino communities to focus a lot of attention on those over 65 and then the kids where we're still lagging. In comparison, if you look at Black Chicagoans, if in the oldest age groups here, you can see that Black Chicagoans are nearly as likely as other Chicagoans, and as likely as Asian Chicagoans to have had at least that first dose in the oldest group, and then are at more than 83%, more than 4 in 5 Black Chicagoans have had at least one vaccine in that 50 to 64. And it's really as we get younger that we see that drop off among Black Chicagoans. So in 30 to 49-year-olds, you can see there's a pretty significant drop, and then especially in the 18 to 29-year-olds, and then boosters sort of continue from there. Now the parents of the 0 to 4, 5 to 11, and 12 to 17-year-olds tend to be in that 18 to 49 group. And so that's where you sort of see this get replicated, because the biggest predictor, of course, of whether children are vaccinated is where their parents are. So I encourage you just to explore this. If you've got additional questions, we've also put some more in here about what's happening with average doses and first doses, vaccination trends by age, just a lot more ability for you to explore at different time points what has been happening. So thanks to my EPI team that has worked to do this, and thanks to all of you who have put in questions and suggestions as we continue to update this. All right, I'm going to move now to some slides. Let me just get into the slideshow. So first of all, a few of you were writing in wondering what's happening with 988. So I wanted to just talk very briefly about this. We're very excited about the launch of 988. It is a national new emergency number for mental health or substance use crises. So the whole country knows 911. 911 for emergencies broadly. But we know that people who are experiencing a mental health crisis, who are thinking about suicide, who need connection to substance use, that has historically been a more fragmented system. Most people, of course, will call 911 an emergency, and you can continue to call 911. But if it is a more specific mental health crisis, this is a new national number. The National Suicide Lifeline is routing to this, and it's going to be a process over the next few years that this will be growing. So July 16, which is this Saturday, the state of Illinois, along with states all over the country, is activating the first phase of 988, which is really to strengthen and expand the existing suicide prevention lifeline. And you can call this number starting Saturday if you have thoughts of suicide, mental health, substance use crises, other kinds of emotional distress, or it's also for people who are worried about a loved one, a family member, etc. Eventually, there will be texting capability here. There will be chatting capability. There will be more connection to crisis responses that are local. Right now, it's set up as a little bit of a kind of a rollover system. It is 24/7, 365, but there will be growth of additional support behind this. So I just wanted you to know I'm very excited that this is launching, although it is going to be a process of months to years for this to grow. But really having a easy to know number that works across the whole country for these kinds of crises is something we've wanted for a long time and are excited to see growing. And we're kind of ahead in Chicago, having thought, I think, more in recent years about what crisis response looks like in mental health crises, how we fit mental health professionals into the 911 response. This is sort of an offshoot of that. And it's not that 911 is going to immediately switch over, anything like that. So this is the beginning of this national number. Okay. Also, continue to get questions about abortion. We have a new website, chicago.gov/abortion-care, which is designed for Chicagoans, but also anybody across the U.S. with questions, needing resources related to getting safe abortion care. It is obviously still legal in Illinois. There's a lot happening around that. We are committed to providing support for anyone in or out of Chicago who needs access to this kind of health care. So I encourage you to visit there if you have questions, and I can also answer some if people have them. Okay, monkeypox quick update here. Again, we spent last Tuesday really with some guests here focused on this. We are up to 105 Chicagoans now who have been diagnosed with monkeypox, most but not all in gay, bisexual, or men who have sex with men, and spread is occurring through these tight-knit social networks. Top line message, if you have a new or unexplained rash, we want you to visit a healthcare provider. If you don't have a healthcare provider, you can call us. Even that's the COVID number. Those folks know how to get people connected if you need care, whether it's for COVID, whether it's for a monkeypox concern, etc. And you should avoid sex or being intimate until you've been checked out. The overall risk does remain low, and based on everything we know now, monkeypox does not spread easily without really close contact. It is a virus, but it is a totally different genus, family of viruses than COVID-19. There's not a relation between them. Generally, people get a flu-like illness and then this rash that can look like pimple or blisters. And spread is primarily through skin-to-skin contact with the rash or with sores, or prolonged intimate contact, kissing, cuddling, sex. This is not being transmitted by passing somebody in a grocery store. This is not being transmitted through casual contact in the same way that we might worry about COVID-19. Again, based on everything we know now, anyone can be infected with MPV. Again, the numbers remain low at this point, but you know, we want to make sure people have the most up-to-date information. Different than COVID, we have effective treatment available. We have effective vaccines available. We've known about monkeypox virus since the 1950s, so there's nothing new about the virus. It's just that it's been spreading human to human in a way that we've not seen in a long time. Usually it's been more human to animal from parts of the world where this is endemic. So again, we have we have treatment available for people who are more likely to get severely ill. We have vaccine, but not a lot of the most effective and safe vaccine yet. So Jynneos is the name of the safer and more effective vaccine. It's a 2-dose regimen. So anybody in Chicago that is exposed, has a close exposure to someone diagnosed with monkeypox, our top priority. We are vaccinating those folks. It's a strategy called ring vaccination. So any known contact, right away, we want to know who that is and get them vaccine. And then secondly, as Chicago has started to get more vaccine from the federal government, and the federal government has ordered more, and this will be ramping up, people with specific risks. We have been offering some vaccine too. So there's testing available. It's a swab of the lesion itself, and that has really ramped up a lot. There's now the capacity to do about 60,000 tests a week across the U.S., including through some commercial labs. So that's good. There's plenty of capacity there. We, of course, are working to identify closer intimate contacts. We're working with event organizers and then developing vaccines specifically for high-risk communities, not recommended for the general public. I went over this last week, but I'm going to just review it again because we continue to get questions. Right now, because of the amount of vaccine that we have received to date, it's kind of like at the beginning of COVID, there just was not enough vaccine for everybody who might want it. And we prioritized healthcare providers. We prioritized those at highest risk. We have not seen spread to healthcare providers, including healthcare providers who have been sampling lesions, et cetera. Although, we continue to follow a lot of healthcare providers and learn about that, but nothing surprising there. So at the moment, the people who are receiving this Jynneos vaccine in Chicago, anybody with close physical contact or an intimate partner diagnosed with MPV, that is our top priority, and all of those folks are eligible. You should, again, work through your doctor, and we can connect with the health department as needed. The other group is that we are proactively vaccinating gay, bisexual, or other cis or trans men who have sex with men, but not just that group overall. People who are in that group and have another risk factor, specifically intimate or sexual contact with other men in a social or sexual venue, or intimate or social contact with multiple or anonymous partners in the last few weeks, or having given or received money or other goods in exchange for sex. And this is primarily because these are particular activities that people may not have the contact information for all of their partners. If we know who the partners are, we're able to quickly go and get that vaccination out there and really work to prevent spread. But if there are, more partners or people are using apps, things like this, these are settings where, especially if we have seen known cases, we've been working with partners to do some more proactive vaccinating. And I expect, at this time, again, not recommended for the general public, including men who have sex with men that don't have these other risk factors. As vaccine supply increases, I expect this will evolve, and we will likely recommend it to more individuals. Go to chicago.gov/monkeypox for more information. All right, to kind of come back a little more on the COVID front, and then we'll turn to your questions directly. So remember, the CDC updates Thursday night into Friday morning the COVID community levels. 59% of the U.S. counties are now at a high or medium level. High is in orange on the map here. Yellow is in medium. And Cook County did move back to medium, but like I said, we're right on that borderline. And here's what we mean when we say that. So there are these three metrics get looked at when the CDC is determining COVID community levels. We look at how many cases per 100,000 population. The goal is to be less than 200. You can see that both the city and the county are just under that last week at 193, 195. So if that tips back over 200, we could tip back to high. Similarly, new COVID admissions per population. The goal is to be less than 10. You can see the city has been actually less than 5, but Cook County and the region have been at 11. And so if both of those two metrics are over the goal, the county is at a high level. If one of them is over the goal, we're at a medium level. If both of them are under the goal, we're at a low level. But the percentage of staffed inpatient beds, we have a lot of hospital capacity generally here in the Chicago area. That one is not a concern. So that's where we are. At the medium, you should stay up to date with COVID-19 vaccines, including boosters. Wear a face mask in indoor public settings where vaccine status is not known. Get tested if you have symptoms. Continue to follow all of that isolation and quarantine guidance. It hasn't gone anywhere. And then, talk to your healthcare provider if you have other risk factors. Here's what's happening with BA.4/5. We've actually not had the national update yet because of decreased testing over the 4th of July and that weekend. So I expect that national update will come soon. But through early July, already nearly 3/4 of the cases here in the Midwest and Chicago have been either that BA.4 or BA.5. So it is very much all here. Everything that we're detecting is Omicron. And if you look nationally, the green are BA.4 and BA.5, and you can see in this case, the Midwest is actually a little bit ahead of where the Northeast is, for example, in terms of seeing BA.4 and 5 come through. So we're getting a lot of people very worried about BA.5. It is certainly what's driving these higher levels, but it's not like it's coming. It's already very much here in the Midwest. We passed the 5 million mark for giving COVID-19 vaccines to Chicagoans, so congratulations. We still have people saying they want to wait and see about getting a COVID vaccine, so I hope knowing that 5 million doses have gone to Chicagoans without significant problems is reassuring to some of you. I already shared this, but about 5%, roughly 7,700 Chicagoans have gotten a dose of COVID vaccine, and it's been reported through the system. The unofficial national estimates are below 2%, which is worrisome, frankly. It's not a surprise that the uptake has been slow, but as recently as April, we had about 18% of parents of children under 5 saying they plan to vaccinate their young children right away. So I've been pleased with how our weekend clinics are going. We do have hundreds of people coming to those. Our at-home is available, but we've got hundreds of places for kids to get vaccinated, but still not seeing a lot of uptake. Just a reminder that you should have had a booster by now. Everybody over the age of 5, unless you just started getting vaccinated, should have had at least 3 vaccines. J&J and then 2 boosters, or 2 Pfizer or Moderna and 1 booster. So everybody should have had at least 3 vaccines. And then if you're over 50 or have moderate or severe immunocompromise, you also should have had a second booster or a 4th dose by now. And this is just some more details about that. Let us know if you have questions about boosters. Our next round of the free Saturday family vaccine clinic starts July 23rd at Kennedy King. You can see the dates that we're at each of the colleges. These clinics are running Saturdays through September 3. They're really nice events. I was at one relatively recently, and they're very well run, very organized. The kids are getting the superhero capes. There's coloring. There's lots of nice stuff happening. So thanks to my team for making these a good experience. And we have plenty of availability, adult and pediatric doses and boosters Saturdays 9 to 2. Our at-home program is going strong. We can vaccinate all the way down to age 6 months and are happy to do that. And then just one last update, and we'll turn to your questions. Just this week, the FDA actually has authorized pharmacists to be able to begin prescribing Paxlovid, which is the oral medication that is most commonly being used if people develop COVID infections. So there are still some limits on this, but it was good to see this get loosened a little bit. Just as a reminder, Paxlovid is authorized for treatment of mild to moderate COVID in adults or older pediatric patients, 12 and older, and at least 88 pounds who are at high risk for progression to severe COVID. So people who are more likely to get hospitalized, et cetera. The big thing about Paxlovid, the other oral medications, the IV medications, you have to take them early. You have to take them within 5 days after your symptoms begin. So this isn't something that you can say, oh, I think I'll be fine, and then a week or two later say, oh, let me take it. These work by stopping the virus from copying itself, helps keep, have it be less of a problem in the lungs, et cetera. So as we think about this expansion of pharmacists, there's no requirement to repeat a positive result from a home test, which is good. But the pharmacist does need to be able to look at some lab work from the last year to know that you don't have liver or kidney problems. So you can bring a lab result, you can log in if you have MyChart or one of the other programs, or the pharmacist can check with your provider. And then the pharmacist also needs to be able to assess for drug-drug interactions. You should bring a list of your medications or, again, that access. Those are the two main things that the pharmacists need to be able to look for to be able to prescribe Paxlovid. So we are continuing to do a lot of outreach to providers about both monkeypox and continued evolution in COVID vaccines. We have a monkeypox webinar coming up with, last I looked, more than 300 Chicago providers are signed up, which is great. And working with our pharmacies and others around this. But vaccine and treatments make this a very different, make COVID just a completely different concern than it was in 2020. And as always, we continue to operate 7 days a week, 312-746-4835. If people need vaccines, boosters, have COVID questions, need resources, etc., you can also visit the website. All right, let's get into your questions. All right. So a number of things here. So first of all, a few comments about removing the positivity rate. Scar on Instagram. Do you think the sudden swapping of the testing metrics in daily posts will erroneously lead people to believe that we're safer than we truly are? The positivity rate increased from 11.5 to 11.7% in a day. Folks need this information readily available to them. So the information, as I showed you, remains readily available. If you go to the COVID dashboard and you click on tests, you can see every single day what the positivity is, what the test is. But I will tell you that a positivity rate moving from 11.5 to 11.7% means next to nothing to the health department at this point, where we are thinking about how we are doing from a COVID perspective. Really, our concern is around, and this is a good thing because we now have home testing available, and that is how the great majority of people are being tested. The biggest changes we see in positivity and in testing, frankly, have to do with things like when school is in session. And there are settings where we continue to do routine testing. We follow that. There are settings that are high risk. We continue to follow that. But the general what positivity means now just isn't what it used to mean, because we also see a lot of people going to get formal lab testing, which, remember, is slower than home testing, et cetera, often if they have symptoms or if they've had a positive home test and they're wanting to confirm it. So you're much more likely to actually also see a positive test. So the information remains readily available, but I've been talking about this since the COVID community levels launched, probably back in March or April, that we would be making this change. And right now, at a time when school is not in session except for summer school, and we're at a reasonable rate of control, I want to continue to make sure that the metrics we are putting out first and foremost are the ones that help reflect the risk. When we see hospitalizations going up, that is because people are getting seriously ill, going to the hospital where they don't have boosters, et cetera. That is something that we act on in a way that positivity just isn't what it means anymore. So you are more than welcome to continue to follow, and we do link to the COVID dashboard from what we're posting, but that is in line with how everybody all over the country is following COVID and how we'll continue to follow it at this point. So thanks for the comment. All right, a couple of questions about second boosters. Bradley Bradley Dlatt on Twitter says, any sense on when the under 50 crowd will get approved for second boosters? That'd sure be helpful given the increased COVID spread in Chicago. And Namrata Batra from Facebook says, plans for a second booster for the general population, ? So I can tell you this has been some of the most significant conversation at the national level. First of all, this would be a national, FDA, CDC, a change in guidance there. And here's what the balance of this is. The reason to do the boosters is especially for people, again, who are at high risk. Europe has still not broadly even recommended a second booster for people over 50 or even over 60. And in that setting, they are starting to really see, not just cases, but hospitalizations really go up. And so there is a general feeling that, especially if people are getting more severe outcomes, you want to make sure those people are protected. So this is why the move and the strong recommendation for anybody over 50, get that second booster, please. Get it now. It does not stop you from getting the updated vaccine that will be coming in the fall. The updated vaccine in the fall is likely to be more protective against infection because it'll cover a lot of the variants that have come along since, Alpha and Delta and Omicron. And so I am most concerned that adults or whoever is recommended with that updated vaccine. I doubt we'll even use the word booster. It's going to be a new formulation of the vaccine that's been brought up to date. And so that one is the one I really want to make sure, everybody is getting when it becomes available. The boosters in the meantime are the most important for people who are older. They really are. One of the reasons we've put that hospitalization data more clearly on the front page is that it's really older people who are not boosted, second boosted. That is who we are seeing get more seriously ill for the most part. So when we talk at the federal level, I think the debate is that there is a lot of unused vaccine. And so could you open it up more broadly for people who are motivated to get it? You could and you might. I think at most you would get a relatively short boost in terms of that protection against infection. And luckily, the protection against severe illness actually remains really good, unless people are moderately or severely immunocompromised or older. I have not, I'm under 50. I have not had a second booster. I've not felt like I needed one based on the information, but I 100% will be looking to get a booster in the fall. So right now, there are not plans for a second booster for the general population. If we were to see a notable surge, which again, especially in the severe outcomes, perhaps we would open that up. But where we're really going to be pushing, and from my standpoint, is when there is an updated vaccine in the fall. So it may still come, but the focus has been more. I'm much more concerned that still, only 50% of the eligible people over 50 have had their first vaccine. That is where the primary focus really is. Okay, a couple of monkeypox questions. Chad Horn from Twitter says, it's infuriating that Chai Public Health won't share information about how to access monkeypox vaccines. I understand you don't have enough doses, but other cities are in the same boat and are far more public and transparent about vaccine allocation. What gives? Justin from Twitter says, when will the city make monkeypox vaccines more available? Chicago is flagging other cities and rollout and messaging, which is a complete disappointment. Okay, so if you would like to put in a little more specifics of what your questions are, like around transparency, I'm happy to share that. I'll talk in some more detail about what that looks like. We actually have shared out on the website and with others what exactly the vaccine allocation has been. We got approximately 1,200 vaccines for the whole city that were allocated ahead of the federal allocation that was announced July 1st. We've gotten at this point a total of about 5,000, it may be 5,400. I don't know the numbers exactly in front of me, but we have it available online. And then we learned that with the additional allocation from the federal government starting yesterday, we would be getting initially an additional 7,000. We've been advocating, maybe we'll get an additional 9,000. And the problem is that these kinds of numbers, 2,000, 3,000, 5,000, 7,000, 9,000, that might sound like a lot of vaccine, but in a city of 3 million people nearly, and a city with a large population of gay, bisexual, and other men who have sex with men. For context, even when vaccine uptake for COVID is relatively low, we're doing 2,000, sometimes 3,000 COVID vaccinations in a single day. So the challenge has been that where some other cities have made more availability of saying we're going to open up an online system, for example, for people to register for vaccine, what they've seen is these systems get flooded with people who want to get a vaccine now. And I love that people want to get a vaccine, but we have to make sure that we have enough vaccine for the very highest risk people, especially anybody who is exposed to monkeypox. And we've had absolutely no problem using the vaccine that has been coming to these highest risk groups. If we had vaccine sort of on the shelf or available, we would be opening it up. And 100%, as more vaccine becomes available, we will open this. But I don't want to give the impression that we can say, sign up for this vaccine when we know that people who sign up won't actually be able to get it. I think that just feeds, frankly, some of the concern, especially around what we saw at the beginning of COVID. So very explicitly, we have distributed vaccine to a good number of providers across the city that specifically serve a lot of LGBTQ individuals. We have also distributed vaccine to clinics that serve a lot of patients who may have HIV or on PrEP, pre-exposure prophylaxis for HIV, which are people who don't have HIV but have other things that put them at high risk. We have also worked with some existing COVID-19 providers to make sure that we have mobile opportunities, and we have done some mobile work, especially at some sites where we have had known monkeypox cases, and there are more examples of some of the higher risk behaviors that I described. So we have been working through some of those groups to make sure that, again, these highest risk people. But the bottom line is that we have to first and foremost, just like with COVID, we had a goal that as soon as vaccine would get here to the city, we would not let it sit on shelf. We would push it out, and that we would prioritize it where it was most needed to control the outbreak. And that is what we are doing. We are not vaccinating healthcare workers. We are not vaccinating others. We are saving vaccine for people who are known high-risk exposures and for people who people who are known contacts, and then for people who have high-risk exposures. And there are, in terms of numbers of what's coming, there are these allocations. The other context is that because this is a rare vaccine, we don't have, it's not like there's just monkeypox vaccine, this Jynneos. It's not just available in pharmacies or through your doctor. The amount of it that we have is what's called the Strategic National Stockpile, which is where the U.S. will store vaccine in case of an outbreak. And so there has been additional orders. The government is going to have about 1 million doses available across the country. They're saying probably early August-ish. It's coming. But then another, multiple million, probably more by the fall. So I get that this is frustrating, but this is why we're trying to be as candid as we can be. And we've been working with all of these community partners. We've had a lot of, every week we've been having calls with sort of MSM advocates and really working on messaging. If you've got other suggestions, you can let us know, but we actually have developed a lot of, palm cards for events. Social media have been working to amplify what our partners are lifting up. And I would encourage you, if this is something that you're concerned about, take some of the information, follow the health department if you don't, on Twitter and Facebook, and please amplify and give us feedback if there are other specific messages. So that's what I would say. Okay, so, and then here's, I see a couple other follow-ups about sort of monkeypox and vaccine. So Brian Valdivia says, there's a limited supply for those eligible to receive the vaccine, but how do you become aware of where and when monkeypox vaccine can be obtained? Yeah, really good question. The main thing we want you to do is see your healthcare provider, okay? All healthcare providers across the city, we've been doing a lot of work, because if you are indicated to get a COVID vaccine, meaning you've been a high risk you've had a known exposure to somebody, or you fall in this other category, we have, even if your healthcare provider doesn't have the vaccine, they're able to get you connected in. The health department can, we've worked to make sure that we've got settings, we've got contracts. Anybody who is a known contact, we can get you vaccine, but that's got to be done through a healthcare provider, because if you need treatment, for example, that's got to be through, there's just a number of things in place, and we've got to get you diagnosed. Getting you diagnosed, or if you do develop a rash, that requires taking a sample of the lesion. That has to be done through a healthcare provider. The Chicago Department of Public Health operates STI clinics, sexually transmitted infection clinics. Those are sites where if people don't know where to go, don't know how to get connected, yes, those are places you can come, you can get tests, you can get connected, but also people who, most of our diagnoses have actually been through primary care providers, which is good. That's what we want. Awareness and as more vaccine becomes available, we'll be working through providers, just as we did during COVID, to roll more of this out. So that's what I would say. Give us a call if you have a specific question about your situation. And I would also just encourage, right now, if you are having multiple partners, for example, or perhaps some riskier behavior, please try to make sure you have contact information. Make sure you've got a phone number. Make sure you know who you've been in contact with, just in case one of you does happen to develop this. The health department can work just like we always do. If people have exposure to an infectious disease, we can work in a way that protects your privacy, but tells people, we think you may have been exposed and we want to get you a vaccine. So that all of that case investigation, contact tracing continues to happen, but we need you to be part of the healthcare system to be able to get the treatment, the vaccine, the accessibility as needed. And then again, some of the very highest risk settings where we have trouble identifying individuals, we have been doing some of the mobile work, but as more vaccine comes, there will be more chances. And where people can be somewhat more careful just over these next few weeks until more vaccine is available, I would encourage that. And that's part of why we've been working to have people understand what the risk factors have been. I'm sorry, and this is monkeypox vaccine, not COVID vaccine. I misspoke there. Okay. I'm going to take one more monkeypox one real quick. Somebody's asking about the smallpox vaccine. So there are 2 vaccines that are in the Strategic National Stockpile for smallpox. One is called ACAM 2000. That's the old smallpox vaccine. People who were born in the before kind of the early 70s, you might have a scar from old smallpox vaccination. Smallpox is one of the only diseases that humans have ever eradicated. So we don't have any smallpox in the world, but the government keeps a pretty large stockpile of that old smallpox vaccine in case of bioterrorism, reemergence, etc. However, that vaccine has real negative, it's not a very straightforward vaccine. You can't give it to folks who are immunocompromised. You can see transmission if someone actually is having exposure to that older kind of smallpox vaccine. If you are exposed to someone who's immunocompromised or a young child, for example, sometimes that child can get sick. It's not like a more where we think of a vaccine having very little risk. And so it's not one at this point that we are using for the general population. The Jynneos doesn't have any of those problems. The Jynneos is a 2-dose vaccine with an excellent safety profile, and that is the one that we are using. If we were to see monkeypox, for example, become a disease that has deaths associated with it, which we've not had any deaths at this point outside of the countries in Africa where there's a strain that is endemic, meaning it's always there, and it is more dangerous. In the current sort of outbreak of this human-to-human transmission, we've not had any deaths, which I'm not at all trying to minimize kind of the symptoms people are having, but we're not seeing people get seriously systemically ill, hospitalized. We are sometimes having to hospitalize people for pain control, for example. So this is a big deal, but where you're doing a risk benefit for vaccinating a large number of individuals, you want to make sure that vaccine obviously is very safe and effective in doing risk benefit. So no, we are not at this point, and neither are other public health departments, using using the old smallpox vaccine with the scarification for this monkeypox outbreak. We are using the Jynneos, and that is what they are buying additional vaccine of. If we were to see a major evolution in terms of that risk, it is something we could consider, but it would not be without potential negative consequences. So thanks for that. All right. A number of people asking about if they should wait for the fall vaccine or get their second booster now. So I see Jeffrey Taylor, we're back to COVID now. So Jeffrey Taylor from Facebook says, I'm in my 60s and vaccinated with one booster. I'm eligible for a second booster. I hear there will be a more Omicron-specific booster in the fall. Should I wait until then and get the new booster with specific protection, or should I get a second booster now and maybe have to wait longer to be eligible for the next one? Get a booster now, for sure. If you are over 50 or you moderate or severe immunocompromised, get that second booster. We are seeing this the reason that Cook is back at sort of this medium high is because of more hospitalizations, and it tends to be in older people. Getting a booster now will in no way disqualify you from getting the updated vaccine in the fall. I don't think that updated vaccine is likely to be available until October or November, and definitely it will be available first and foremost to people who are older and have risk. So I would 100%, if you're eligible, get it now. And then I'm trying to not even use the word booster for what's coming in the fall, because it really is an updated version of the vaccine. And we may be at a point where every year, kind of like with flu, we're making a new version of the vaccine that is a match and helps protect. So yeah, good question, Jeffrey. Patty Graff from Facebook. If you're already 4 months past your second booster at high risk for severe outcomes, are you still protected, or will there be another booster? I don't think there will be another anything if you're totally up to date until that fall vaccine, which again, should help, because it'll be updated against variants, should help a fair bit with adding not just as the severe outcome protection, which the vaccine remains very good against, but to more of the protection for individuals. So no additional information. Faith State, similar question. Should a senior get a second booster now or wait? Get a second booster now. She's asking, if you were going to get a second booster, how long would you have to wait? I am not anticipating any waiting time, frankly, before that new vaccine. Certainly, it's far enough out that if you get a vaccine now, regardless, there wouldn't be a waiting period. We may get to a point where we might encourage people, if we know on the horizon there's an improved booster coming, let's say in October, we might say, and I'm making this up, I want you to be clear, we might be saying in September, hold off at this point for the new one, but for July, August through September, please get that second booster now. We've got the most infectious variant yet that's circulating, especially if you're at higher risk. And then everybody, I intend for sure to get the updated vaccine in the fall. Okay. Amanda DW on Facebook. Lots of scary articles in the national media. Again, yes, this is why I'm trying to help you put this in some context. BA 2.75 is India. How concerned are you? So a lot of the scary article, their variants continue to worry people, and they should worry people. Every time we have a new variant that emerges, it's the part that is the least controlled with COVID. If the COVID virus didn't mutate at all from here on out, I would have no questions about what we do to sort of get us out of COVID. The problem is, because it keeps mutating, because we keep seeing new variants, every time that happens, in some way, the virus is changing to be more contagious, which is most of what we've seen, but there's the potential for it to become, more serious. There's the potential for it to become less serious, but you just don't know for sure. And that uncertainty is part of what makes it very hard to fully be able to predict the future. But overall, I'm seeing some of this, like with the BA.2.75 in India, people who haven't been following it, it's about a quarter of the cases right now in India. It's sort of competing with BA.5 there. It does look to be contagious. It, at this point, doesn't look to be more serious, but we're still learning. It's not been named a variant of concern at this point. So we're watching it, just like we watch other variants. It will be, we will let you know if there is a variant that is behaving in some seriously different way, or where, remember how there's a variant of high consequence? We've never had a variant of high consequence. If we get a variant of high consequence, like the vaccine really isn't working, there's a major change in terms of how it's behaving, that would potentially mean some change to what we're doing in public health. Other than that, variants of interest, even variants of concern, we're watching really closely to make sure that we continue to see protection against severe outcomes, and knowing that there should be improved protection for breakthroughs coming as well. So we've had at this point a few cases of that BA.2.75 out on the West Coast in the US. It's been seen all over the world. We probably will see more cases. Whether it'll outcompete BA.5, we just don't know at this point. What I can tell you is we have good surveillance, meaning laboratory capacity here in Chicago, which we didn't have before COVID. We collect samples from across the city. We look for variants. We've got wastewater going on. We've got lots of things that help us stay on top of it. And, these super scary ones about BA.4/5, we already are in our BA.4/5 wave and doing okay by and large. And then a couple of other people. Lisa Balde-Venaria on Facebook. It seems like usually what happens in New York comes to Chicago soon after, with cases and hospitalizations going up. Is that something we're expecting to see? So in this case, the reason I showed you the national map is that Chicago in the Midwest actually has seen our BA.4/5 wave ahead of New York this time. And that's part of why we kind of have already seen most of our cases, and we got to that majority of cases being BA.4/5 before the East Coast did. And so in this case, they've actually been more looking at us to see what's happening in Europe. Europe is just now seeing the BA.4/5 really increasing. They've not done boosters as much in Europe, and that is showing up in more hospitalizations. So I am not, I don't love BA.4, BA.5 in that it is the most contagious yet. I don't love the BA.2.75 that we're just keeping an eye on. But most importantly, we're not seeing any change at this point in terms of protection against severe illness or major change in severity. And while that remains true, it's about getting up to date with your boosters, wearing your mask indoors, especially if you're in settings where you don't know vaccine status, testing, isolating, quarantining. There's not magic to this, but we do have the tools. And then getting the treatment if you are at high risk and come through. All right, Tanika Hilton on Facebook. Hello, my daughter is 10 and got her first vaccination of Pfizer back in December 2021. Can 10-year-olds receive a booster? Good question. Yes. Anybody over the age of 5 can and should receive a booster. So I would definitely recommend, again, in this current BA.5, 6, whatever, not 6, 4, 5, whatever's coming, I do recommend for kids to get that booster. I'll tell you, just in my extended family, like many of yours, that we're seeing some COVID outbreaks right now. At this point, in some of the families, it's the youngest child who is the most recently up to date with COVID vaccines boosters that has not yet been diagnosed with COVID, even if some of the others have had breakthrough. Yes, so I would recommend, and you are welcome for 10-year-olds, for 5-year-olds, for 35-year-olds, for 95-year-olds. You can get that vaccine through your provider, through a pharmacy, through our at home. We'll bring it to your house free of charge, or through any of our vaccine clinics on Saturdays through September. Okay. DS Shin from Facebook. What's the first thing I should do if I have COVID? Put a mask on if you're around anybody else, and let your provider know, please, because if you have COVID, we want them to be aware of it in case you need treatment if you're at higher risk. Also, you should, and then they can, if there needs to be additional reporting, you should let your contacts know. We have some information on the website for how you can do some self-notification, even anonymously. If you have any questions and you test positive, if you have needs, give us a call. The team is really helpful about getting you connected to a provider if you don't have one. But really, you should, the first thing if you test positive for COVID is not to feel guilt and shame and huge amounts of worry. If you are up to date with your vaccines, you're very unlikely to get seriously ill. If you are someone at high risk, we want you to get that that treatment also, which drops your risk of hospitalization by 80 to 90%. And you should know that there's a lot of COVID around right now. And so the last thing I want is people not wanting to test because they don't want to know the answer. That doesn't help anybody. So it is a positive thing if somebody tests and is like, oh, I'm positive. Often your work will want to know that you've been positive, because in the 2 days before you test positive, you could have been spreading it. Hopefully you were wearing a mask indoors, etc. So it depends on your situation. But, stay home, isolate, put your mask on. For folks in the home, let your doctor know. The very first order we passed here in COVID, the number one emergency order was stay home if you're sick. And I would say at the end of the day, that's probably still the number one thing in terms of, from a public health perspective, working to limit this spread. I answered this last week. A Carbo 425 on Twitter is asking again, or maybe somebody else asked the same question. What is the off-ramp for 5-day isolation? When do we treat this more like any other virus, staying home if you're sick, 24 hours fever-free? So I answered this on last Tuesday. But the thing is, this virus, you continue to transmit it for 5 days. And in fact, in some cases, and with Omicron BA.4 or 5 especially, we're seeing a lot of people continue to test positive, even on those at-home tests, day 6, 7, 8, 9, even into day 10. So that 5 days of staying home is pretty non-negotiable. Like, we really need you to do that. That's when we see most of the spread. It's the highest risk. And then days 6 through 10, remember, you can be out and about, but you got to have the mask on. So different diseases have different incubation periods, different times of spread. If you had the measles, you would get different guidance about how long you would need to stay home. So we do treat all viruses differently, actually, depending on how they behave. COVID remains incredibly infectious. And so I don't anticipate any change coming to the 5-day isolation requirements if you do test positive. Activate Chicago Parents on Twitter says, why has Chai Pub Schools not announced that COVID vaccination is required for fall 22? So if you're referring to students, we are still waiting for the final FDA approval of a vaccine for kids under 12. So we have now had the full FDA authorization for kids age 12 and up, as well as adults, obviously. But for those younger ones, remember, after the initial authorization, there's a period of monitoring where they look to make sure there's no additional concerns, where they do all the investigation of the plants, where they're making it. There's just a lot of extra work that comes. And it's at that point, actually, after full authorization, that pharmaceutical companies are able to advertise any vaccine or medication. So until that full authorization is in place, really nowhere in the country is planning to require vaccination for students yet. It is, of course, very strongly urged, but it is not required. Staff, there's some different conversations, of course, but we continue to talk regularly to Chicago Public Schools. I know they've got a lot in place. They're using summer school also to be working on really making sure protocols are tight. I have every confidence in their preparations for the fall, but I will leave that for CPS to answer. Obviously, we advise them and they set their policies. Francie Swidler, we're just about at time. I'll get just one or two more. Actually, here's a quick one. M. Dizzy from Twitter. I keep getting this one. Is there evidence that COVID damages your T helper cells? Not more than sort of other viruses are. We're still learning about, what makes somebody potentially have long COVID. What are the issues? But we're not seeing evidence, and this is one of the things that I've been just hearing a lot of, which is why I took this. We're not seeing evidence that COVID is, getting multiple vaccines in some way, like hurts your immune system or lets you not push back. Like, I've seen no evidence to indicate that. We've also not seen any indication that COVID infection in any way sort of weakens your T cells. If anything, every time your body sort of learns that lesson from exposure to COVID, your immune system gets better at fighting it off. So the safe way you learn the lesson to how to fight off COVID, the safe way you do that is through vaccination. But every time your body is exposed and sort of fights it off, you get better at fighting it off. We've not seen that in any way additional infection or additional vaccination decreases your immune system's response. So if that's your question, I want to reassure you that is not, of the many things that we worry about, that's not high on the list, although we continue to learn about it. And then Francie Swidler is asking, what symptoms are most associated with the newest variants? I'm hearing some people get night sweats. Is that part of the latest subvariant? Yeah, I mean, we're seeing a lot of upper respiratory symptom. We're seeing a lot of cold-like symptoms. Certainly the flu, fevers, the night sweats can come with the fevers. Sore throats again. We are seeing people continue to lose taste and smell, but not all of them. Nothing really significantly different, I would say, but just more symptoms. It's a more virulent infection in terms of it's especially the upper respiratory. I don't have time to kind of go into the immune piece of this, but your immune system has multiple ways to fight off a virus. There's the initial, like when the virus first enters kind of your nose or your mouth, and then there's the backup, which is some of the T cells, et cetera, B cells, that and the backup vaccine system, your backup immune system, that is what the vaccine teaches you about, that's working really well. So that's why we'll see people kind of get infected, and we'll see a lot of these like upper respiratory symptoms, meaning the cold-like symptoms, et cetera, without, and because this is moving so quickly, people are getting infected very quickly, it doesn't take very much virus, that it kind of gets in so quickly that the immune system that is more immediate, that kind of sits in your nose, that one doesn't get activated quite as fast. But the backup immune system actually does come in pretty well. And that's why we're not seeing people, for the most part, get it in their lungs, get it in the sort of, the putting people in the ICU or even the hospital like we were previously. So those upper respiratory symptoms, there's a theory that that's why we're seeing more of those, just because it is moving so quickly. It's not evading the more kind of important long-lasting immunity, but it is evading some of that mucosal immunity. And that's why, we may have a nasal vaccine that becomes more of a thing at some point here. The scientists continue to work on evolving protections, but thankfully, when people are vaccinated and boosted, every single time you do that, your immune system is getting better at fighting off COVID. And that's why for people who are older or immunocompromised, we really do recommend that booster again right now, because it helps, it helps you fight this off. Okay. Oh, here's a quick and easy one. Sarah Garza on Facebook. I got my second booster July 5th at Osco Drugs. The label said that it expired in July 2022. Does that mean that the second booster is not good? No. It means that it had to be used by the end of July. So thank you for getting your vaccine, your second booster just now, and there is no problem at all. Vaccination is end of the month for those. And obviously, pharmacies, doctors, everybody is keeping these in the appropriate, even if it were after July, I wouldn't have major concern, but we don't, if they expire on the shelf, they expire on the shelf. So no concerns, you are good to go. All right, we got through just about everything. I will be back next Tuesday at 11 a.m. Thank you again for your thoughts and comments and questions. You can always give us feedback on, particularly some of the monkeypox stuff. Please check out the website if you want more information. And if there's specifics that you're more interested in, I can bring some more questions about that next week too. I'd also refer you last Tuesday, the whole thing was about monkeypox. So for those of you who are interested in strategies, there's more detail there. Thank you. Have a good week, and we'll see you again next Tuesday. Bye-bye.